Yes, thanks again. And when I was asked to speak about this topic, I realized that my approach to anterior segment dysgenesis is to ask three questions. The first is it syndromic? The second, is it inherited? And the third, is there glaucoma yet? And my time is limited, so let's go through some cases to illustrate my approach. I showed you this case earlier. This is a child who came with classic aniridia. When we have a child with sporadic classic aniridia, we're worried, of course, about the eye, but more importantly is whether or not this is associated with a predisposition to Wilms tumor. Why do these patients with sporadic aniridia have a predisposition to Wilms tumor? Well, the PAX6 gene, which when mutated causes classic aniridia, sits right next to the gene WT1. And if you have a new deletion that's large enough to hit both of those genes, you of course will get classic aniridia, which is the most visible thing that you see right after birth. But that classic aniridia could be a marker that WT1 has been knocked out and there's a predisposition for Wilms tumor. So it's these patients that are sporadic classic aniridia where we have this concern about the predisposition for Wilms tumor. And this is one of the situations where I feel genetic testing is strongly indicated, because you just basically look to see if WT1 is deleted or not. We don't have this same concern with familial aniridia, because in familial aniridia, typically the mutation is within PAX6. And so if the mutation is within PAX6, it's not conferring a risk for deletion of WT1. So much more relaxed when you have a familial case of aniridia. Now here's a child who came in. With congenital aniridia and also congenital glaucoma. PAX6 mutation typically doesn't cause congenital glaucoma. It's often an acquired glaucoma, but it's not impossible. So a patient like this should be analyzed for PAX6, and more importantly, WT1. But this analysis was negative. It wasn't really clear to me what this baby had until she got a little bit older. And as she got older, she developed some of the extraocular signs of Axenfeld-Rieger's abnormality, and this child had FOXC1 mutation. So FOXC1 and PITX2 are two genes that, when mutated, cause Axenfeld-Rieger spectrum. This is a large spectrum of anterior segment dysgenesis, which can range just from posterior embryotoxin to frank aniridia, lack of iris, and congenital glaucoma. These patients, when they're born, extraocular features might not be apparent, but it's an important point that in children, phenotypes evolve. And of course, you can't appreciate that a child has pointed teeth before they develop teeth. You can't appreciate they have a small jaw until they get a little bit older, the facial features develop further. Immediately, when you see a patient with Axenfeld-Rieger spectrum, the first thing you should do, or the first thing that I do, is look at the parents, because this is a dominant disorder with variable expressivity. And sure enough, the mother had undiagnosed glaucoma. It was actually quite advanced, and she didn't even realize it. She had the same FOXC1 mutation, but because of variable expressivity, she just had some mild iris hypoplasia. She didn't have frank external findings. It's just an extreme example of how this variable expressivity in anterior segment dysgenesis can be so marked, comparing this mother to her child. FOXC1 and PITX2, as I said, are genes classically associated with Axenfeld-Rieger spectrum. It's a very large spectrum of anterior segment dysgenesis. Basically any patient with an anterior segment dysgenesis could have mutations in these genes. There are extraocular features associated with mutations in these genes. Most of the time, these extraocular features are mild. They're not actionable. You don't really have to do anything about them other than sensory neural hearing loss. But sometimes there are more significant extraocular features. So it's good to identify these patients. It's much better for the patients and for genetic counseling as well in terms of recurrent risk, and identifying other family members who might be affected and they don't even know it. We have a responsibility not only to the patient, we have a responsibility to the family as well. Here's another family with anterior segment dysgenesis. This family had microcornea, cataract, iris abnormalities. And this family had mutation in another gene that's important to be aware of. This family had mutation in the gene collagen 4A1. And this is another gene associated with syndromic anterior segment dysgenesis plus or minus glaucoma. Mutations in this gene are associated with a microangiopathy of the brain. And sure enough, when these patients were further evaluated, they had a microangiopathy that they didn't even realize. Mutations in collagen 4A1 are also associated with nephropathy. It's important to identify these patients. The findings, the microangiopathy is not always actionable, but sometimes it is. Sometimes there are prophylactic measures, and the same can be said for the nephropathy. So collagen 4A1 is another gene to be aware of in children who come in with anterior segment dysgenesis. Here's a 2-month-old boy with congenital glaucoma. And when I first saw these patients, I used to test them for PAX6 because I was worried about aniridia, congenital aniridia. But I now know that this is not the phenotype of congenital aniridia. This is a phenotype of iris hypoplasia. This is not a dilated pupil, partial iris ectropion, and a central corneal opacity that's actually intrinsic to the cornea. It's not from increased intraocular pressure. This phenotype is pathognomonic for CYP1B1 mutations. It's a very bad anterior segment dysgenesis phenotype. But if you see these three things together, partial iris hypoplasia, congenital ectropion uvei, and a central corneal opacity like that, it's CYP1B1 mutation. Bad news in terms of the glaucoma, it's very difficult to control, but good news in that it's not associated with any syndromic features. And at least we have that information when we identify the phenotype. Here's a 2-year-old who was told there was nothing of concern when he was brought in to an ophthalmologist by his mother. The mother had noted an abnormal pupil. The ophthalmologist examined the child under anesthesia, found there was normal IOP, normal nerve, diagnosed congenital iris nevus, and told the family there was nothing to worry about, it's just a congenital abnormality. 1 year later, the patient came with uncontrolled glaucoma in the left eye, extreme cupping, and actually a lawsuit was initiated against the original ophthalmologist because the family was told there was nothing of concern. This child had congenital ectropion uveus syndrome. It's a well-known phenomenon where you have congenital ectropion uvei of one eye, and there's a mild ptosis. And what's the problem with this condition is that they develop a juvenile glaucoma. So although the iris abnormality is there at birth, just because they don't have glaucoma at that time, that doesn't mean they're out of the woods. They have to be followed lifelong for the possibility of developing glaucoma. And actually, most of these patients do develop glaucoma, very severe glaucoma. The point here is that when you have an iris abnormality, even if everything is fine, you still have to follow these patients for the development of glaucoma. So that brings me to the end of my time. In summary, anterior segment developmental abnormality can be caused by different gene mutations or no detectable gene mutation, as in the congenital ectropion uveus syndrome, which is a well-known syndrome, but there's no known genetic basis. It is important to recognize when anterior segment developmental abnormality is the sign of potential syndromic disease, and I've given you some examples of that. It is important to recognize when anterior segment development abnormality is potentially hereditary, because we have a responsibility to the family, not just to the patient in front of us. And finally, whether or not a child has glaucoma when they're examined with anterior segment developmental abnormality, a child with such an abnormality is a glaucoma suspect for life. Thank you.